Good afternoon, everyone. My name is Colin Hung. I'm the editor, one of the editors at Healthcare IT Today. We're a publication, online only, no paywall. You can come and look at all our articles all the time. I'm excited to be here on the health stage to talk about a topic that doesn't get enough attention, and that is data, right? We don't have enough of it. Oh, sorry, that's wrong. We have too much of it, and we need to better organize it, and we need to use it for AI, and we're going to get into that. And by the end of this session, some of you in the audience will be patting yourselves on the back to say you've got good data, and others will have the justification to go back to your CFOs and CEOs to say we need more money because we need better data. But to tell the difference, you're going to need the help of this panel. So I want to keep it fun, but I want to keep it light. If each of you could just quickly introduce yourself, name, title, organization, and you have to complete this sentence. Good data is like eating blank. All right, Lauren, we'll start with you, Lauren.
Thanks, Colin. I'm Lauren Riplinger. I'm the Chief Public Policy and Impact Officer for the American Health Information Management Association. And having good data is like eating puffer fish. As long as it's properly cleaned and appropriately managed, it can be quite delicious. If not, the consequences
Wow. That is good. Charlie, you have a big,
Yeah, I got to follow that. Yeah. I'm Charlie Harp. I'm the CEO of Clinical Architecture. And good data is like eating something that allows you to survive.
Ooh, okay.
Not as good as a puffer fish.
But good, all right.
So I'm Viet Nguyen. I am the Chief Standards Implementation Officer for HL7 International. And good data is like eating good sushi. You know when it's good and you know when it's not good.
Okay. All right. So a lot of sushi lovers up here. Okay. All right. Okay. Let's get into it. Thank you for the introductions, by the way. All right. So let's talk about data. And maybe just start, if each of you in less than 45 seconds can you define what good data means to you? Dr. Nguyen, we'll start with you.
Sure. I would say good data is accurate, appropriate for the patient, and has utility, whether it is immediate and direct patient care, or it's in retrospective analysis, or as the topic of the day has been, useful for developing AI models, because if you have crummy data, your models aren't going to be very good.
Data quality is a continuum, going from poor to excellent data. Good data is the tipping point at which the data is usable.
Wow. Okay. Lauren?
So much like Viet, I would say good data is accurate, complete, and timely, and ultimately it leads to better patient outcomes.
I like these answers. You guys are great. 45 seconds, you're under the limit. By the way, if you guys have any questions, please go to your app, the health app, and enter them into the questions for this particular session. I'll see them up here on my phone because I'm not actually taking notes, and I will ask them of the panel later on. So thank you for defining that. Next question, how do you tell the difference between good data and bad data? Lauren, we'll start with you this time.
So I'd say it's really the inverse of what we just talked about, right? If it's not accurate, it's inaccurate is an indication of bad data, right? You might have bad patient demographic information. It's incomplete, so you may be missing medication or allergies or things like that. And it's untimely. The labs might be outdated, the images outdated. So it's really, again, the inverse of the accuracy, completeness, and timeliness.
I like that time factor that you added in there. Charlie, what about you? What's the difference between good and bad data?
I think it's subjective, honestly. I think when people talk about, historically that we've had good data, it was because of what they were trying to do with the data. I think whether or not data is good or bad really depends on what you're trying to do with it. If it satisfies what you're trying to do and it has the right granularity and timeliness, then as far as you're concerned, the data is good. As soon as we move the needle to the right and we try to do more with it than what it can handle, then it becomes bad data, even though it might be the same data it was before.
I like that. Okay, Dr.
So I think part of your question was how do you tell the difference between good and bad data? I think a good chunk of that is sampling. Sampling the data that you're getting to make sure that it's accurate, it's timely, of course, but when it comes to coded data, that it has the right codes, that the units are correct, things like that. So it takes individuals who understand the domain and have some informatics expertise, I'm hoping, to take a look at that data and tell you that it's to the spectrum of quality.
So a follow-on question to that then, I think an easy way to tell bad data from good data would be when something's missing. But what are the other ways that bad data, if you have bad data, how does that manifest for like a provider or a payer that may be in the audience? If I have bad data, what is the consequence for me? How will that show up for me? Charlie, let's start with you on that one.
Sure. It's kind of a tricky question because it's like operating against bad intelligence, right? Sometimes you won't know until you're so far down the road that you've made so many bad decisions that you look back and say, wow, why did I make those bad decisions? And it's because you had bad data. You can measure the data, you can evaluate the data at a granular level, you can look at the components and the conformance, but at the end of the day, how you know you got bad data is because you're not doing the right things.
Lauren?
I would say the most severe consequence is patient harm at the end of the day, right? That's what we know when we have bad data. But from the provider perspective, it also means that we have lower reimbursement, which I know many in the audience have probably thought through that and struggled with it. It also means incorrect billing. It means skewed clinical research. So there's a variety of different downstream factors that result when we have bad data and the consequences associated with that.
So I work for an organization, HL7 International. Who knows what HL7 is? Oh, okay, that's not so bad. So we are a standards organization, healthcare data standards, and we're the stewards of the FHIR standard, Fast Healthcare Interoperability Resources. So organizations and vendors are retooling their software in order to support FHIR data standards so that you're exchanging information in a highly interoperable way. I think that's a good opportunity to see how good your mappings are, because if you can't support some of the data that is under regulation, that's going to limit you. And in particular, coming up in January 2027, we're going to have electronic prior authorization. And the payers are going to define their rules around prior authorization and the data they need to adjudicate that. And if you don't have that data, you're going to potentially get rejected, or you're going to have to do that really manual process of gathering data and then send it to the payer, which will delay care for patients. So having good data so that you can send information to another entity is very important as well.
I like what you said there, Charlie, because important around, you won't know until you make a bad decision that maybe your data was at fault. But is there anything other than that end of it? Like, that seems to be waiting quite a long time. Is there some sort of quality measure of data that we could look at or anything like that would be able to point that out? Lauren, you look pretty anxious to answer too. Go ahead.
Let me jump in. No, I would say for our members, they are health information professionals, right? So you're talking about medical coders, clinical documentation improvement specialists. So when they look at the data, one of the indications of when they have bad data is you have upcoding, you have undercoding, you see different coding of the same patient across different departments within an organization. So there are some trends, I think, that can tend to indicate that you have a data quality issue before it gets to that patient harm, but not everyone necessarily puts towards the resources when we think about data quality.
And when it comes to data quality, one of the things that I've been working on, and we've been working on with others across the industry, is this patient information quality improvement framework. And the idea behind the patient information quality improvement framework, or PIQI, is that we need to understand the quality of the data that we're exchanging in flight. Because right now we're building all this plumbing to be able to push data from point A to point B, whether it's HDUs or QHINs or whatever we're doing to push the data around. The question is, how do you know that the data you're receiving from someone else is good? And I think the problem we have is people tend to think the data they're getting through those vehicles is not good. And PIQI is all about how do you measure the data against a use case to say it's acceptable or not. And then not just say, hey, your data's bad, but to tell somebody, here's what you need to do to fix your data. Because I would argue that it's not like we have a bunch of nefarious actors in healthcare sending out bad data on purpose. no one's ever really tried to use it, so they don't really know. So we owe it to them to say, this is what's wrong with your data, and this is what you need to do to fix it so I can start using it.
And it sounds like there's an element of context in there too, right? Like, as you pointed out before, Charlie, just because data was useful in one instance, it may not be as useful in the second instance. And so the intent of use of data is also important to determine the quality of the data.
Absolutely, and it goes back to FHIR as well. You know, data in and of itself is this big, ambiguous, amorphous thing. But if I'm doing med reconciliation, I care about the meds. If I'm doing things with your lab results, I care about the labs. And that's where you have things like implementation guides that say, hey, this thing has to conform to this syntax. It has to have these terminologies so that it can be accepted by somebody who's trying to do these specific use cases. Because if all I care about is demographics, your lab data could be horrible, but it's still good enough for me. Does that make sense?
Dr. Nguyen, you have a
Yeah, I agree. The use case matters. And the simplest example is blood pressure. We have a model for exchanging blood pressure that just says, this is the blood pressure, systolic and diastolic. That is great for your primary care doc, almost everyone. But if you're a cardiologist, you want more granularity. You want to know the pressure in the left ventricle during systole, when the heart squeezes. So we go back to those use cases and making sure that we have the right data to support those use cases and they have the right granularity. And often the right coding too, because coding is the way we can translate from one set of data to another set of data, a similarity. So that's really important.
So one of the biggest use cases, we've already heard it in the last panel as well, one of the biggest use cases for data, of course, is AI. And we can't have a panel in 2025 without mentioning the word AI. So to that end, and this is something that one of you said on the prep call, how do we ensure that the data we have in order to train our AI ends up with actual artificial intelligence instead of artificial stupidity? How do we do that? Because my big worry is our data is not clean, and yet we're training all this AI on the data we currently have. How do we know that the result is actually going to be artificial intelligence? Charlie, let's start with you.
Say who you asking.
Okay.
So I think that is one of the things that I tend to say, Colin, when I talk about artificial intelligence. And I think that we have to remember that tools like AI are accelerants. So, and AI is heavily biased by not only the data that it's trained upon, but the data that it's prompted with. And in healthcare, we all kind of agree that the data that we're moving around is not the highest quality. And so when we start taking this data that's not the highest quality and we start using it to prompt AI to help us make decisions, really what we're doing is we're accelerating what could be a potential data quality problem. And if we're really going to leverage these things, and by the way, this is nothing new. I mean, the same thing was true for quality measures, clinical decision support, analytics. They all require good quality data to provide good results. And so I think AI is a very useful tool. We just have to figure out how do we use it in a way that's safe so that we don't put people in a bad situation.
Dr. Nguyen?
So 20 years ago, when I was starting my career or finishing my residency, I had to go to McMaster University outside of Toronto and learn about evidence-based medicine. The AMA has been really into that space. You know, how do you read an article about a diagnosis or treatment or prognosis? So we took that knowledge back to teach the residents. If they're going to say, I think this patient needs this test or this treatment, they need to be able to defend themselves with an article, and not only with the article, but why was that article good? And so this is where I'm struggling a little bit. How do we do that with AI so that the clinician who has a tool that is a very powerful tool to digest a lot of information and come to some conclusion, how do they know that it's right and it's good? And does it come from an institution that is known for maintaining good quality data? So I think it's a matter of the data coming in, as Charlie mentioned, but as the data coming out as recommendations to clinicians, they need to be able to be have good speculation of whether or not it's good or bad. So it's just not a simple, I'll do whatever the AI says and that's fine.
Lauren?
I'd say going back to Charlie's point, ultimately we have to make sure that, and you're probably going to hear this a million times this week, but you have to have a human in the loop when you're leveraging these tools. Someone has to kind of keep their eye on the tool and make sure that the data that's going in is of higher quality and that it's producing the outcomes that are intended to produce. And related to that means that you have to have a skilled workforce in order to understand how do we leverage these tools and maximize them, whether it's on the clinical AI side or the administrative AI side.
Can I add one more thing?
Absolutely.
So I'm going to plug my podcast, the InfoMonster podcast, but I did a podcast that went out this week where I interviewed ChatGPT about AI. I asked it about using AI in healthcare. It was actually really interesting. And you know that when you do the voice thing with ChatGPT, it breathes? It freaked me out. But yeah, it goes, and I said, can you add filler words? And so it started saying like and It was great. But I did that after I interviewed it. But what was interesting is it started off, I said, what do you think about AI in healthcare? And it said, well, Charlie, AI in healthcare can be very powerful, but it should never be used in delivering clinical care to patients. And I said, well, what should it be used for? It said, well, it can be used to do summarization of all their information. It can be used for this and this. And then I said, well, if AI is being used to summarize all the clinical data for the patient, isn't it indirectly getting involved in clinical care since it's taking responsibility for doing that? And it said, you're absolutely right, Charlie. That's an excellent question, which is what AI does. So I think to that point, it's interesting. It's very attractive to use AI. It kind of has a snowball effect, on anybody that starts to use it, because you're like, well, that was easy. I didn't have to do that stuff I normally have to do. But we just have to be very careful in critical use cases.
By the way, I'm about to do something I've always wanted to do on stage. Yeah, I know. Getting ready for the next. Actually, this is a question here that came in, and I thought this is an appropriate time to ask it. This comes in from Chris Page. He's asking, executives want ROI from better data, but data quality work is mostly invisible. It prevents bad outcomes rather than creating billable ones. How do you make the financial case for something that shows up only when it fails? Great question, by the way.
So I'll take it from the provider side. I mean, I think about our folks, many of them report into the CFO, and it's really, again, maximizing that reimbursement. I mean, that's how at least our folks make that argument to their leadership within their organizations about, why it's important to have data quality. Totally agree that it's really difficult to measure, and particularly when you're thinking about causation and can you prove that it was data quality that led to this improved, better outcome. That's really tough, and that's something that we as an organization have struggled for a long time. But focusing in on that reimbursement piece is really critical, particularly in the changing regulatory environment, which I know we'll talk about in a little bit.
Mm-hmm. Charlie?
I mean, I was at a conference where somebody said prevention doesn't work when it comes to healthcare. And I thought that was interesting because in a lot of ways, data quality, us working to improve the data quality, which is a lifestyle choice, it's not a project. It's kind of like if you go to the doctor and the doctor says, Charlie, you have this problem and you've got to take care of yourself or you're not going to make it. And you go, well, yeah, but nobody can see that. Nobody can see the heart valve replacement. Nobody can see the fact that I'm eating fewer carbs. So I'm just going to get a haircut because that's something that people will see. And so it's an uphill battle. And I think the problem is you won't see it bend the cost curve for a little while because getting to the point where you've improved the quality of the data, it is a lifestyle choice. It's kind of like getting healthy. You have to get to the point where you see the results, but you will see the results in super powerful and meaningful ways. So there has to be kind of a leap of faith, but it's not a big leap. It's so common sense to think that if we have better data, the millions, maybe billions of dollars we've invested in infrastructure will pay off. Because right now, for a lot of folks, it isn't.
Yeah, and I mentioned this earlier, and going back to Lauren's point, we're going to have electronic prior authorization. It's going to be, we're trying to get rid of portals, and we're trying to get rid of forms, and using technology to gather the data on behalf of the provider and sending it to the payer. It will become very clear. Things that got PAs in the past suddenly stop getting PAs now that the payers are using algorithms to evaluate the data. So you'll start seeing it, and hopefully you'll see it, the signal early to really look at your data to make sure, because it's going to cost money and delay care.
Well, actually, on that note, while we're talking about justification, are there any regulatory changes or any policy changes that are coming down the pipe that maybe people in the audience can use to help justify further investment in data quality? You mentioned one, Dr. Nguyen, about the...
So the electronic prior authorization is, we call it the burden reduction rule. It's CMS 0057, and that builds upon CMS 9115 back in 2020 to really start to get vendors to implement FHIR so they get better interoperability, have more payers and providers using FHIR for exchange. And so those are the big ones. But if you look back in April, we called it the month of RFIs, because in a bunch of rules that came out, there were RFIs hidden in the rules asking, what do you think about data quality and data standards in this domain, to get feedback from the community. And I think that's going to reflect potentially in future regs, unless the industry adopts standards on their own.
Yeah, I would agree with Viet. The data quality request for information from CMS indicates and signals to us that the agency is interested in this topic. The other two, I would say, one is the Assistant Secretary for Technology Policy is planning to do a deregulatory rule soon. And one of the provisions that we are hearing that could be stripped is a certification criterion called DSI, Decision Support Intervention. It basically means that health IT systems have to certify to certain provisions, whether or not they have an AI tool within their system or it's bolted on. And these include really going to transparency of how the tool functions. So it includes things like source attributes, scope of how the tool works, those types of things. If that provision gets removed, as we intend it, as we expect it to at this point, there's a real concern from the end user community of, this is one of the few tools that's out there right now that gives me visibility in terms of how these tools function. You take that away, I think it opens up a data quality question of, when something goes wrong, is it a function of the tool not working properly, or is it that I put bad data into the system that resulted in a bad outcome? The more longer-term regulatory action, I would say, is the Medicaid cuts that are included in the BBB, or the Big Beautiful Bill, from earlier this year. We are seeing health systems already start to pivot towards, how do I maximize reimbursement and make sure that we don't leave money on the table? Again, as I mentioned earlier, right, of data quality and reimbursement, I think you're going to see a lot of health systems invest in this area in order to make sure that they are trying to adjust to these cuts in Medicaid.
Charlie?
And I think, I mean, we're in an interesting regulatory environment right now, where to put one regulation in, you have to take 10 out. But if you look at what's happening with CMS has a very big investment in using AI, specifically to look for fraud and abuse in Medicaid, Medicare. And they realize, to be able to do that, to leverage AI, you need good quality data. And so you're seeing a lot of initiatives, and if you've read like the Kill the Clipboard document from Levitt Partners, there's a lot of potential initiatives around things like digital quality measures, around things like the electronic adjudicated claims in FHIR, as well as the stuff that we've been working on with PIQI Alliance, because if you can have an objective measure that's an HL7 standard that says here is how you score the quality of data for a particular use case, like Social Security and CMS, then that can be something that helps people guarantee within that rubric that the data meets the usability standard necessary to drive that kind of functionality.
This is a question from Jeff Furbush. He asks, how should we think about the benefits of aggregating data in a confidential way, and how can we use that data to improve patient outcomes? I'll pick on Charlie first on this one.
Oh, geez. We're all deer in the headlights. He picks on me. I think that, when it comes to aggregated anonymous data, which is really what we're talking about, the question is, how anonymous is that data? Because obviously, one could argue that if we take all this data from a bunch of patients and we aggregate cohorts in a particular disease state, then we can feed that to AI, and AI will solve all these problems for us, assuming the data quality is good. So I think that it's one of those things where we have to get our house in order. We have to understand what the quality looks like. We have to understand how we're leveraging that through things like terminologies and standard formats. If we want to have a prayer to be able to do that, and then obviously, the question is, can you use somebody's data anonymously without their permission? And I don't know. That's not my area of expertise.
Dr. Nguyen?
So I would do 2 points. Maybe not the aggregate, but on the individual patient level, the data quality is really important because we have this opportunity in this phase of phasing into FHIR and computable data to start looking at care gaps. And we can do that programmatically, not just chart review. So we can say, I have this whole horde of patients, tell me who needs a colonoscopy in the next 90 days that I'm supposed to report to a CMS or a payer. So using that, the data, you have to have good quality in order to pick those patients out in order to intervene. In the same way, you need to aggregate the data because I'm not sure if we're going to accelerate, decelerate, or stay the same when it comes to value-based care. But in value-based care, it all comes down to the agreements you make and how good the data can support the care you deliver. So that data quality becomes very, very important because it's not about reimbursement on a claim or getting a prior auth. It's about your relationship with the payer and getting reimbursement at a pretty big scale. So that's a good argument for having good data quality.
Lauren, anything to add to that?
No, nothing to add beyond that.
All right.
Colin said.
Okay, so I got to put my glasses on for this one. This was a question from Tucker Stass. He asked, Dr. Nguyen, where would EPA go in the future if not based on a form or a portal?
AI. Because the way, I'll briefly nerd out with you all, the way EPA is going to work is provider is in the room with the patient, wants to get a study, let's say a head CT. The provider is unlikely, I'm going to say, because I've been at the bedside, know what insurance the patient is on, let alone whether or not the CT is a covered service or requires a PA. So in the background, the systems are supposed to know who the payer is, reach out to the payer, know what SNOMED or CPT code you're asking for, and ask, does this require a PA? If it doesn't, that's useful information for the provider. And if it does, it opens up a second part of the EPA process called document templates and rules, where the payer defines the data they need based on FHIR, and you get either a static form or a dynamic form, and you enter the data. But it's not just about entering the data. FHIR and the tools will pull the data from the EHR, saving the provider time and energy in retrieving information. They package that all up, send it over to the payer using FHIR because we have a enforcement discretion around the X12278, and ideally you're going to get a real-time adjudication from the payer, and that's really useful. But over time, as the payer gets more and more codified data and sees how their rules are working against them, ideally you have a provider wants to order a service for a patient with a particular payer, and they're consistently good about it. They're doing the right thing. Maybe we just give them the prior auth number and go to town, move on, deliver care to the patient. So I think there's a lot of opportunity for AI as we gather more data.
If I can add to that too, I think in addition to what Viet said, I'd say yes and, right? The other key piece is trust is going to be critically important in terms of partners. I have seen these technical standards work and demoed, and it is amazing in terms of the workflow and how that works. You have to have trust between the partners on the payer and provider side in order to make this effective, and really making sure that, as HL7 has done with the Da Vinci project, making sure that end users are at the table with the payers to make sure we're building technical standards that support that workflow at the end of the day.
This is an excellent question. It's from Wayne Pan, and he asks, how can patients be empowered to correct incorrect data that gets swept up into these large data sets that no one seems willing to take responsibility for? We have ways to make changes to credit data and credit monitoring services, yet there's nothing analogous in healthcare data. I like that question. Anyone want to take a stab at that, Charlie?
I mean, it's kind of like getting those pictures off the internet, right? The problem is now that we're exchanging data, so let's say somebody goes in and puts down that you have allergic rhinitis. You don't. But they add it to the record because they want to get reimbursed or whatever. And that enters the ecosystem. And as we start exchanging data, that hops over to somebody else, and that hops over to somebody else, and hops over to somebody else. The problem is we don't have a central control. Let's just bypass the fact that we really don't trust patients to correct their own medical record. But even if we did, where do you correct the medical record? So having a central place, which, ideally in the future we'll get there, but you need to have a central clearinghouse where somebody can look at their medical record and say these things aren't right. And today there's just too many silos that have copies of the data.
Anyone else want to add anything?
I mean, I would say under HIPAA, you do have the right to amend your record. It's just making it actually happen is really where the rubber meets the road, right? And it becomes more difficult. And to Charlie's point, as you start to exchange that data and it's incorrect, it goes to multiple different places. I would say from an aggregate perspective, we don't have a good answer on that today.
I'd like to ask, how many in the audience look at your record using your provider tools or any other tools?
Handful.
Excellent.
All seven of them?
Right.
So if you aren't, you should be. All the major EHRs have their platforms. But I'll give a pitch for FHIR. With FHIR, using Apple's Health Kit, you can look up all the providers that you're being seen and pull down that data into your phone. It doesn't exist other than the provider and your phone, so it's not aggregated anywhere. But it's a really good way to look and see if the notes, the meds that they've listed are correct or not. And it's really useful. I forget what immunizations they might need. So it aggregates all the immunizations for me, which is really helpful as well, given that we're going into the winter.
I like it. All right. This is a question from one of my favorite people. Dr. S.D. Garrity is in the audience from Esri. She asks, as health systems work towards more interoperable, high-quality patient data, how can we expand our definition of data quality to include location accuracy and geographic context, given their influence on pop health, access, and care coordination?
I'll try to tackle that one.
Yeah, go ahead.
So I would put the items, the data that was mentioned, under the rubric of social determinants. Where you live matters. Your access to healthy food matters. Your access to transportation matters. And so those are just a few social determinants of health. And HL7 has a FHIR accelerator called the Gravity Project that is creating the data elements to capture that data so that it can then be used. I think the then be used part is still work in progress. But if we don't capture the data and then we can't utilize it to improve the patient's care and access to care.
Anyone else want to comment? Okay. All right. Let's ask this one. So this one's from Jeremiah Scholl. He asks, seems to me that the biggest data problem is that EHR systems are designed around ontologies that are imperfect. Why should physicians even need to know that ICD exists? Instead of using coders, how soon will AI enable EHR systems that can fully run on only unstructured data?
That's an interesting question. I think that perfection is unattainable. There's no such thing as a perfect ontology. And at the same time, I don't know that a codeless or a termless backend for healthcare solves the problem. Unstructured data is very squishy, for lack of a better term. The terminologies we select give us guide rails that we can follow when we're doing things. Now, I agree that the interface between what the provider's doing, and this is why some of the scribe stuff we see is really cool happening right now, is the best technology is invisible to the user. So moving us down towards something where something is collecting the data, and turning it into actual clinical data would be really useful. The biggest problem we have in this country, and it's a little different when you go to places like Australia and countries that are single payer, is we don't really have clinical systems in this country. We have cash registers in this country. And we try to take the data that we capture for the processes of scheduling and billing and these things, and we try to transform it into clinical data. But we're not, and there are probably some systems doing this better than others, but we need to at some point transform what we're doing in the EHR to capture clinical data, real clinical data, probably at a higher level of granularity than what we do with these big chunky pre-coordinated terms that we use today. Because that's, if we really want to drive AI, we need to give it something much more higher resolution, much more closer to what the provider has in their head, so it can make better decisions.
All right. Anyone else want to chime in?
I'll just say, very similar to Charlie, as long as we have our current structure of our healthcare system in the United States, ICD and things like CPT are not going to go away because they are such a critical piece of making sure that those claims continue to flow through our healthcare system on a daily basis.
All right, we got a question here from Jason Woods. He is saying that it seems like many of the data quality issues discussed on this panel can be addressed through proper data governance. Can you speak to your data governance efforts and how those might be falling short? Or maybe the reverse, how is it doing well? Data governance.
I mean, I would say where it's falling short, how much of it is a priority inside your organization? I mean, that's really, there's so many competing pressures that happen at that leadership level. Data governance doesn't always necessarily rise to the top. Now, if you start to see financial pressure, it may come up at a higher level, right? And rise to the top. But today, I think it's really just those competing priorities.
It kind of goes back to what I said earlier. It's a lifestyle choice. It's hard. Getting the data right, doing the work, it's challenging. And when you look at a health system or a payer or somebody in life sciences, they have a lot of things they're trying to do, and finding the right people and the right processes to actually collect the data appropriately, make sure you're normalizing it properly, make sure you have people that take care of it. I mean, one of the questions I ask people when I meet them on the street, this is why people avoid me, is who do you think is responsible for your data? There's no data steward in healthcare. You're not allowed to do it. The provider has no time to do it. The payer doesn't have time to do it. And so it's one of those things where it's just super challenging. And even people that try to do it, I think, struggle, and they just have to commit to it. It has to be a lifestyle choice.
All right. So on a related note then, Michael Kerwin has a question. Insurers are imposing a huge administrative burden on providers by sending out letters saying that some care is not done or incorrect based on incorrect information that the payer has on that patient. It is then on the provider to investigate. Can the insurers do their own investigation to check whether their information is wrong, and do they have that obligation?
Are we authorized to answer that question? Yes.
Okay.
Absolutely.
I think the question is more like, is there a way we can maybe incentivize that? Because what you're saying is so true, Charlie. I think there's no one entity that's responsible for this. There's no general data steward. So if there's incorrect information in here, we've talked about the fact that it is really hard to get rid of it.
Well, and if the data on the patient is better, you're less likely to order things that are inappropriate for the patient. And that goes back to the question of fraud and abuse and misuse of resources. Improve the data so that it can actually help us from stop doing that.
Yeah, seems to me we need some sort of system where if you win or I win, one of us gets paid for the work that we had to do to prove it, right? Or something like that. I don't know. Maybe arbitration. Anyways, all right, last question as we close off here. What is the one key takeaway that you hope the audience walks away from this panel with? Lauren, we'll start with you. What's the one key takeaway?
I'll say good quality data is not something that's going to be solved overnight or merely with a tool, but it really comes down to people, process, and technology.
Charlie.
If you say it 6 times, people will remember data quality is a lifestyle choice, which is essentially what Lauren said, but better. She said it better. I said it here.
We get it. Dr. Nguyen.
So I'm going to continue with Charlie. It's a lifestyle choice, and choose that. Go back to your organization.
Choose quality.
Choose to take the time and effort to have quality data, even if it's not clearly an ROI. It's important for patient care, patient safety, and your institution's bottom line.
All right, well, I want to thank the panel for being such great panelists. Thank you, all of you, as well. Thank you.